Okay, well, hello everybody. My name is Bruce Korf. I'm a medical geneticist, serve as the chair of the Department of Genetics at University of Alabama at Birmingham. Pleasure to have an opportunity to speak with you today. And I was asked to talk about the educational challenges brought about by the opportunity to integrate genetics and genomics into medical practice. I know that you have the opportunity to ask questions, and my plan is to, you can ask questions at any time, but we'll take all of the questions after I've had a chance to complete the presentation. Also should note that I do not have any conflicts to disclose relevant to this talk. By way of background, I think it's well understood that there is a huge opportunity before us in terms of using the power of genetics and genomics to inform healthcare. But at the same time, there has been a lot of concern about the degree to which the healthcare community is prepared to embrace genetics and genomics. I quote here from a report from the Secretary's Advisory Committee on Genetics, Health and Society, and I won't read the quote to you, but it's an example of the kind of concern that has been very widespread. Most physicians in practice, and I think this would apply to other healthcare professionals as well, did not train in the genomics era. So even if they were exposed to concepts of genetics during their training, the world has changed almost 180 degrees since the time that they did train. So very, very few non-genetics professionals currently in practice trained for the current environment, never mind the environment yet to come. So there is a challenge in terms of the pipeline of professionals, but then especially a challenge in terms of the current practitioners for them to get up to speed on what is, in many respects, a kind of sea change in the way medicine is going to be practiced. A lot of my comments then will follow from this challenge. Where are we? What are the kinds of things that might be possible to do in order to bring us to where we all, I think, would like to be? I'm going to tell you a short anecdote which maybe casts into relief some of the challenges that we're facing. And this is a case that was seen in our genetics clinic. And it concerns a child who comes from a family with a history of multiple endocrine neoplasia type 1. It's an autosomal dominant trait, and the features are shown up in the left side of the slide, multiple endocrine tumors. I won't read all of these to you, and in fact, some non-endocrine tumors as well. He came to attention because of chronic diarrhea and was referred for evaluation to a pediatric endocrinologist because the family history raised the question of whether the diarrhea might have been on the basis of having inherited the gene for this disorder. So the endocrinologist went ahead and did a genetic test on the child, and oops, right button here. The test was sent to a commercial laboratory. Now, I'm not showing you the actual result as it came back from the lab, but this is a reproduction that's pretty much the same as what the report said, which is that they found a mutation in the relevant gene or variant, and somehow, not exactly sure how, they positioned it about midway between the possibility that it was a pathogenic variant and a benign variant. As I'm sure you're aware, genetic variants by themselves sometimes can have significant phenotypic effects. Other times they have no phenotypic effects, and this one somehow was placed right smack in the middle. Well, the endocrinologist actually interpreted this as being indicative of the child, in fact, being affected. And the medical record was then indicated that this child had inherited a multiple endocrine neoplasia gene, and the care was adjusted accordingly. We'll say in a minute what that means. Well, some time passed, and the mother then was seen in an adult endocrinology clinic because of various medical concerns And the endocrinologist was not entirely convinced of the diagnosis in the family, and as a result, sent testing on her. But the way it was arranged in this case was that she was referred to the genetics clinic, and his expectation was that the genetics clinic would order the testing. And it was done. It was sent to an academic lab who identified a known pathogenic mutation, that is to say, a mutation that had been previously documented in other families and in other individuals as being responsible for multiple endocrine neoplasia. It was different than the mutation that the child had been found to have. And in fact, the mother was not found to carry that variant of unknown significance. So presumably it came from the father and is not a pathogenic mutation. And the child, as best we know, did not have the mother's pathogenic mutation. I put it that way because the commercial lab assured the counselor that they would have seen this pathogenic mutation if it were there. And so at this point, it was clear that the child had in fact not inherited the pathogenic mutation in the family. By the way, did verify the mother's diagnosis. And I can tell you that it's been difficult, and probably to this day, depending on where you look in the medical record, you might get the impression that the child indeed is affected, since it tends to be very difficult to undo an erroneous diagnosis in the medical record. So if you conceptualize the kind of case in terms of competencies that you would hope that a clinician would have, and I'm thinking of the child's physician, you would say, well, the first thing you'd want to know is that they paid attention to the family history and determined that the child actually could be at risk based on the pattern of inheritance of this disorder, and that competency was demonstrated. You can say that the child would benefit from having a diagnosis. That's actually questionable at 18 months. The recommendations for follow-up do begin in children, but maybe not quite that young. On the other hand, the child did have a potential symptom, and so you could argue that that competency was achieved. Incidentally, I failed to mention that when all was said and done, the diarrhea was due to gastroenteritis. The third is to know how to order MEM1 genetic testing, and clearly that competency was achieved. And then to appreciate the variant of the significance of the variant of unknown significance, in particular to realize that unknown significance, well, means unknown significance and not establishes a diagnosis. And here, I think you can say that competency was not achieved. In fact, you would really prefer to test an affected, known affected relative, that would have been the mother most probably in this case first, because the significance of a mutation test is much greater when you know the family mutation, and then a negative test means that the child didn't inherit it, as opposed to that maybe the diagnosis was incorrect or the mutation couldn't be identified with current technology, and that clearly was also not exercised here. Formulated a appropriate care plan. I guess it's kind of an ambiguous point because you would have had to have the correct diagnosis to do that. So really, my point here is that there are many competencies that you would expect of a, in this case, specialist, some of which were evidenced and some of which ultimately were not. So you could ask the question, what are the necessary knowledge and skill sets that are required for analyzing, interpreting, and utilizing genomic information? And one of the major themes that I would like to set forth is that we need to be focusing on competencies, not knowledge. In this case, the competency is the broad competency of utilizing genomic information in the context of a clinical question, and that can be in turn broken down into many specific competencies, such as I did on the previous slide. I would argue, as we go forward, I will, that point-of-care decision support tools may guide clinical use, at least in some circumstances, but also that doesn't get the health provider off the hook for at least having some idea of what they're doing. And the stern visage of Abraham Flexner, who wrote a report about 100 years ago that moved the US medical education system from the kind of trade school approach that had been prevalent at the time to the scientific basis for medical practice that all of us know today, will remind you of the importance that we don't expect health providers only to just know which buttons to press, to have at least some idea of what's going on behind the scenes. Not necessarily an intimate idea of all the nuts and bolts, but at least not to believe that the results come about due to magic in some way, shape, or form. So what I'd like to do briefly is to consider very broadly 3 kinds of scenarios, that is prevention of disease, diagnosis, and treatment, and provide some suggestions of how and where genetics and genomics are likely to be used and what we would expect of various of the health providers in the context of providing this care. Well, the first example with regard to prevention is actually a well-known one with which many physicians are quite familiar, this being newborn screening. We have practiced newborn screening for inborn errors of metabolism in this country and throughout the developed world for about 50 years now. The paradigm began with the idea illustrated at the upper left in phenylketonuria, that if you made a diagnosis at birth before toxic accumulation of phenylalanine took place, that you could avoid the kind of dire outcome shown at the lower left by avoiding dietary intake of phenylalanine and achieve the much more satisfactory outcome shown at the right. And over the years, in various states in the US and around the world, the paradigm has expanded to multiple inborn errors of metabolism, and this got a big boost in the 90s and to the present day with the advent of tandem mass spectrometry. You don't need to know that much about it from our perspective to realize that it has the ability to detect abnormal metabolites of very large variety of types, as opposed to the old Guthrie plate, which is what the woman in the center of the upper left panel is looking at, where you had to custom design a specific panel for each particular disorder that you were trying to diagnose. Well, in fact, one of the challenges that you encounter when you expand the newborn screening panel, as has been done, and now there's a standard panel that the American College of Medical Genetics and Genomics has put together that is used in most, if not all, states in the US, improving a situation, by the way, that used to be the case, which was depending on where you were born, determined what you were screened for. But the challenge now becomes, if you're the physician, presumably usually a pediatrician, who receives a call from the state lab Friday at 4:30 in the afternoon that your patient has just been found to be screen positive for a condition that very probably you have never heard of, and if you ever did hear of it, you probably haven't seen another patient with it, are not likely to be intimately familiar with the way management is done, and although you are almost certainly going to seek support from a metabolic disease expert, you do need to be the first responder for the family to deal with things in the immediate few hours at least, or days, before you can engage a specialist consultant and tide them over the kind of immediate needs. I'm showing you on this screen a set of shots of so-called ACT sheets that are put out by the American College of Medical Genetics and Genomics. This particular one involves a very long chain acyl-CoA dehydrogenase deficiency, a rare disorder to be sure, one likely not on the kind of tip of the tongue of most pediatricians. And basically what it's intended to do is to tell you the immediate things that you need to pay attention to. And what are the things you would do for the hours or days before you get a specialist involved, and it provides simple algorithms. And I make the point really, it's obviously not really genomics, but it is a kind of paradigm of providing point of care decision support systems that actually are intended to be embedded in electronic health records. So at this point, they're more likely to be available online as web-based assistance. But the concept here is that it helps the physician get through the day. It would be unrealistic to teach all pediatricians how to take care of all the inborn errors, but this is a way of kind of holding their hands through the immediate things that they need to pay attention to. And I think the paradigm potentially is a powerful one. What about in the area of risk assessment? And I show a screenshot of 3 companies that either have been or are in the business of offering direct-to-consumer testing of usually 1 million or so single nucleotide polymorphisms. These can be accessed over the internet, with the paradigm being that you send a saliva sample to the company, that they test for these polymorphisms, and then give you access to usually web-based information that walks you through various disease risks that might be identified on the basis of this analysis. Not all of the companies that started in this domain are still in business doing this. So perhaps the marketplace has spoken to a degree. It's created a lot of angst in terms of consumers accessing this information without the intervention of a physician, but there are many that would take the point of view that it's the individual who owns their own genome, more or less, and therefore should have the right to information without a medical system telling them that they can't see it. I think that whatever you believe about that concept, that you could conceptualize this direct-to-consumer model as an example of a so-called disruptive technology. It's a term perhaps some of you are familiar with that has been coined in the business community. This is a chart modified from a kind of canonical chart that Clay Christensen, who's popularized this concept, has put together. The idea is that we are currently functioning in a kind of traditional mode shown on the red line of a physician and or counselor meeting in a room with a patient, one gene at a time, one patient at a time. And as time passes, as we get more information about the genome, the quality of those visits should improve. You sort of march up this curve, but not that steeply, because it's a pretty mature paradigm, one that people have a lot of experience with. In contrast, the consumer-driven testing at this point in time is the green line, and that we're at the bottom left corner where the performance is really not very impressive. And I mean by that, that the quality of the risk data is questionable. It's based on mostly genome-wide association studies. The odds ratio of having disease, given the presence of a particular marker, is usually very modestly changed from the population risk. There could be questions about what population was actually tested and whether it applies to the particular population of a given consumer. So some people have called this kind of recreational genomics, and it's interesting and maybe fun, but debatable about how much it informs your healthcare. And you can take different points of view on that, but whatever you believe, I guess I would at least suggest the possibility that as the quality of the data sets get better and better, we may sort of march up this green curve to the point where it actually crosses the red line and becomes the sort of sustaining technology. You know, an example of a disruptive technology is the personal computer, which in the 1970s was really nowhere near capable of doing what a mainframe computer could do, say, to run a business. And as you know now, the personal computer has really dominated the computer industry. So perhaps the same thing will happen, perhaps not. It's always hard to predict disruption before it's occurred, but at least I posit this for your consideration. What about diagnostic testing, and how has genomics changed all of that? The paradigm we're most familiar with is like sickle cell or cystic fibrosis, illustrated here, where we're focusing on single gene disorders where a particular genetic test targets a very specific mutation. This is not always so easy. The lower right shows a diagram of the neurofibromatosis type 1 gene, which happens to be my area of special interest, and the lab here at UAB offers testing. and each dot below the gene represents a different mutation in a different person. You know, the opposite as in sickle cell, where everybody has the same mutation. CF is a kind of middle ground where a few mutations comprise the majority, but after that, there could be potentially thousands, and in NF, no one mutation is more than a few percent. So it ranges in complexity from fairly straightforward to extremely challenging. Now, we are in the era of genomic testing for clinical purposes. The example shown here in the upper right is a cytogenomic microarray. You can probably barely see it, but it would be capable of detecting at the very bottom an exceedingly small, in this case, deletion, well below the limits of light microscopic resolution, and yet which can explain, for example, autism spectrum disorder with a much higher diagnostic pickup rate than classic cytogenetics, for example. And most recently, the concept of doing exome or even genome sequencing has been introduced as a clinical test, with the goal being to avoid the so-called diagnostic odyssey, where patients are seen, clinical problem is subjected to differential diagnosis. You make your best guess as which test to do, it's interpreted. If it's the wrong test, you don't get an answer, and you just keep going in circles here, sometimes for years, costing a very large amount of money, and often not casting light on what the ultimate diagnosis is. In recent years, the possibility of doing genomic testing with an eye towards identifying specific pathogenic mutations increasingly is being used and is being covered by insurance. We do have to realize that diagnostic testing based on this approach will often pick up things that may or may not be the original target. I'll say more about incidental findings in a few minutes. This is a screenshot from a paper published a few years ago and basically shows that just the frequency of carrier status for recessive disorders, virtually everybody is a carrier for something. So if you set the bar at that level, they're all going to turn out to have things that may or may not be relevant to our health and may or may not be relevant to the question being asked. So it's a complex area, and they also found many examples of what were thought to be literature annotated disease mutations that in fact were not correctly annotated. So one has to take some of the genomic data with a bit of a grain of salt, or better stated, with a critical eye and a sophisticated critical eye, and not to take at face value results that may not have been completely vetted. Sometimes these mutations were based on a single case report 30 years ago that may or may not hold up to modern scrutiny. Well, we've been doing genetic testing in even common disorders for a while. This is an example of a family history, a proband shown at the lower right, with a sister with breast cancer and a family history on her father's side of multiple people with breast or ovarian or prostate cancer, was concerned that she might be a BRCA carrier. We organized to test her sister, who had breast cancer, and her sister was test positive for a BRCA1 mutation. That permitted us to test our patient, and when she was found to be negative, that has a very substantial power for her, because we know that the family history was accounted for by a BRCA mutation, and we know we could detect it and didn't, and that means her risk reverts essentially to the population risk, not informed anymore by her family history. So diagnostic testing for risk of at least the Mendelian versions of common disease has, I think, at this point become mainstream. So what competencies do you expect of a physician? Some of these I've already talked about with the multiple endocrine neoplasia family, to recognize the indications for testing, know the right member of the family to test first, not always so straightforward, and also could be challenging in terms of who's going to pay for the testing. You need to be able to discuss that very point and what the risks and benefits of testing, including potential anxiety and stigmatization, to then correctly select the lab, interpret the report. If it's genomic sequencing you're doing, to recognize the potential for secondary findings, to make appropriate referrals, and to discuss the results. That may or may not be the kind of definitive discussion. You may engage a genetic counselor to help with that, but you still need to be prepared at least to support the family. What about in the therapeutic realm? Well, lots of things are going on there. I show here a screenshot of the kind of structure of the BCR-ABL fusion gene in chronic myelogenous leukemia, which is targeted by the drug imatinib mesylate, which represents a very well, I think, known example of tailoring a particular drug to a particular genetic lesion. It's a paradigm that sort of stands as the holy grail in many ways of new therapeutic development. Probably don't need, honestly, to know a lot about genetics to use it. You need to know a lot about genetics to develop it. And that's something that continues, but you do need to at least know that genetic testing will stratify patients with disease as to whether they will or won't benefit from this in certain circumstances. I realize you can't see this well, but this is meant to indicate the ability to do testing of the EGF receptor in breast cancer, looking at response to drugs that target that, or a particular BRAF mutation that determines sensitivity to specific drugs in melanoma. And now, increasingly, even whole genome sequencing is being applied in cancer therapeutics to make a precise diagnosis and to select the most appropriate mechanism of treatment. So we have moved towards a kind of so-called precision medicine model, at least in some areas, especially in cancer. There are also pharmacogenetic polymorphisms that can be tested that provide the possibility of adjusting drug dosage according to the metabolism of a given individual. This diagram shows the metabolism of warfarin, very commonly used anticoagulant, where the VCORC1 target of warfarin is subject to polymorphisms that determine its sensitivity to warfarin, and the CYP2C9 gene is involved in metabolism of warfarin. And you can use testing of the two of these to identify the likely optimal dose of warfarin for a given patient. It is pretty clearly clinically valid. It is still being subjected to clinical trials, though, to establish clinical utility and cost effectiveness. This is an example, I think, of a kind of test that is likely to be incorporated into electronic prescribing systems. Whether physicians will ever need to know in their head how to adjust drug dosage for warfarin, I'm not so sure, but you can easily imagine it would sit in the background in a electronic prescribing system and then inform the drug dosage that is chosen. Well, a lot of people have wondered about the possibility of genome sequencing, and actually as I look at the slide, I can see some errors in terms of the translation from the platform where they were created to the display platform here, but I don't think it has any major effect. The question would be, should everybody have their genome sequenced? And if they did, when would you do it and where would you keep the information? It's possible to actually do a prenatal genome sequence, even on the very small amount of fetal DNA that is released usually from the placenta into the maternal circulation and is now already being used for non-invasive prenatal screening, could be used for even prenatal genome sequencing. You can imagine doing it instead of the newborn screen metabolic test that's currently done, that I've already talked about. Either of these raises a lot of questions about, do you want to know about adult onset disorders prenatally or in the newborn period? You could do it in childhood. You still have at least the possibility of intervening, but the complexity of knowing about things that are not immediately relevant to the health of the child. Or you can do it in adulthood when you can certainly provide informed consent about the procedure. But if you wait till then, you have lost the opportunity to intervene at an earlier point. And if it were to be done, you could ask the question, where would the information live? So one possibility shown at the lower left is in the electronic health record, which probably makes the stewards of these records in different institutions a bit nervous to realize the vast storage requirements that would be expected of them, although probably storage will become cheaper and cheaper as time goes on, making that a possibility. But another challenge faced is that most people do not spend their entire lifetime receiving healthcare from a single place, wherever it might be, academic or otherwise. People tend to move around over time, or you might be traveling when some medical event occurs that requires, or at least would be informed by, genomic information. So not clear whether the EHR is the right place to put this unless electronic health records share information back and forth more than they currently do. You could store the information in the cloud, wherever exactly that really is, as long as you trusted the security of the information, and maybe that would be a solution if it's already being considered in many cases. Maybe you would store it on some kind of personal device you carry with you, which is fine, as long as you don't forget it. Or, and this is becoming my favorite, so far as we know, the most efficient place to store genetic information is the cell nucleus. And nobody ever forgets to bring their cell nuclei to the doctor. And it may be that the cost of sequencing will plummet to a point where it's essentially almost free, and it will be cheaper to repeat the sequence as needed than to bother storing it anywhere. I actually just don't know which of these various possibilities or any combination of them is likely to take effect, and really ignoring here the vast effort that needs to go into annotation and the informatics, although I predict that that too will become a lot easier as the technology improves. But argue that the paradigm that we really need to be seeking is to find a way to store and process information which is as user-friendly and fun to use as iTunes, which is the screenshot you're looking at. And I'm often asked, when do I think physicians will use genomic sequencing in the course of their day-to-day treatment? And my answer is the day that somebody creates an iTunes-like interface instead of the, in my opinion, very awkward electronic health records that most of us are using that were really not built for the genomic era. And unfortunately, are so expensive and complex that they evolve very, very slowly. I've alluded to the possibility of incidental findings, and I show this picture as a kind of paradigm. We're looking at a guy that was just hit on the head by a flower pot that fell on him with a passerby trying to come to his aid. And I used that sort of picture because probably many of you know that in the last year, the American College of Medical Genetics and Genomics has proposed that laboratories that are doing exome or genome sequencing query 56 genes for specific types of mutations. An example would be the BRCA1 and 2 genes, that those results be returned to the referring physician, regardless of whether the test was done for that reason, that the patients not be asked whether they do or don't want those lab results returned. The idea would be that the physician understands the patient's circumstances better than the lab does and can contextualize the results, decide what and how to share with the patient, and provide appropriate support and counseling in the process. It's been a controversial recommendation. The genes were chosen very carefully. I'm sure we've left some off that could potentially find their way on the list, and I doubt that the list will stay just as it is forever. But the thinking was this is a bit analogous to finding an unexpected pulmonary nodule on a chest x-ray that's being done to see if somebody fractured a rib. You don't ask, do I want to know about the possibility of incidental cancer identification or potential cancer? It's not even then a guaranteed result that it would be a cancer. We assume that that kind of thing is too important to ignore. And that was the same spirit in which these recommendations were made, though I know that there's been a lot of debate about how this could be implemented and whether patients should be given more opportunity to opt out of this. And it's a debate that's likely to continue, although my personal belief is that these are conditions that are so overwhelmingly penetrant and medically actionable that it would really be hard to argue why a lab would not report these if they knew they were present. But anyway, that can be discussed at another point. Well, to kind of get to the sort of end point here in terms of education, what are we faced with? If you look at the human genome, you can conceptualize it as this file of letters, and many people have likened this to so-called book of life, or I like to think of it really as the library of life in a way. And you can kind of remember back to your training and say, well, what's the language of the genome? And the answer is 3-letter codons that encode particular amino acids. So it would be possible to say, well, so what's an example of a book that uses predominantly 3-letter words? And the one that comes to mind is this one. And it would be possible to say, well, just how hard could this be if things are as simple as that? And my feeling is that this is not a very good metaphor for the genome, that in fact, the better one, if you want to use a literary metaphor, is this book, which any of you who have tried to read it will acknowledge it's not easygoing, that you could teach a first grader to read Ulysses, I would expect, if what you mean by that is pronounce the words, but the complexity, the knowledge you need to have of the allusions that are used in this book, the ability to read between the lines and to get the kind of backstory that the author is communicating is very, very sophisticated. And frankly, that is very similar to what we're dealing with in genetics and genomics. It might look simple from a distance. The farther you get into it, the more you realize that it has complexities that are not that obvious. Finally, another literary metaphor is it doesn't take long to pass through the looking glass in genomics, where the rules you thought you knew and were taught don't apply, where a gene mutation, for example, that should obliterate expression of a gene actually changes splicing patterns, not turning off the gene entirely, or conservative mutations, or even mutations that don't change the amino acid alter splicing patterns unpredictably, or imprinting effects. So that this is a lot more complicated than it sometimes seems on the surface. So what are the training needs? And I would argue here that we need to establish what you could think of as a vector of competency that begins actually before matriculation into professional education. For example, in undergraduate years, we need to then enhance that through their medical education, and for physicians through residency training, and then lifelong learning through continuing medical education and maintenance of certification. And the latter may be an area of opportunity for the already practicing physician. We also need to do a better job attracting students to careers in genetics. From the perspective of both pre-medical and medical school education, the Howard Hughes Medical Institute and Association of American Medical Colleges a few years ago issued a report shown here on scientific foundations for future physicians, where they tried to identify the competencies in basic science that would be important for future physicians. And one of their recommendations was to enhance the scientific training in the pre-medical years so that students came to medical school better prepared and then could carry that forward through medical school. This is a very high-level document, meaning not a lot of fine detail about particular curricula. This is the one competency that addresses medical education in genetics. And as the one geneticist on this committee, I guess I can take responsibility for what was left out of here. But it really is a kind of all-encompassing thing. You might say this is covering a tremendous amount of territory, and it is. And this kind of competency is paradigmatic of what was done in other medical specialties too. And it leaves the details, of which there obviously are many, to faculty in terms of actually how to instill these competencies in the medical schools and medical students in training. A few years ago here at UAB, we actually extended this concept to not just the undergraduates who are in pre-health professional type programs, but also to general undergraduates, thinking, maybe you're not going to pursue a career in health professions, but if you're going to be a consumer of so-called personalized healthcare or genomic medicine, you need to be a more sophisticated consumer. If you're headed to a career in business, law, or engineering, there are opportunities. And we broke it down into genomics, pharmacogenetics, informatics, and cultural and environmental influences on health, and tried to identify competencies that would be useful in all of these and customized to these different, usually undergraduate, or in some cases, graduate education kind of modes. So there's a lot to be done in terms of preparing physicians in general for the use of genetics and genomics, and for building a professional genetics workforce also. The genetics community has met twice about this in recent years at the Banbury Conference Center near Cold Spring Harbor, once in 2004 and then again in 2006. The first of those meetings was focused on how can we increase the training pipeline into genetics, and the second into defining what the medical geneticist actually does, since it was a relatively new specialty that has come of age originally in the pre-genomic era and now in the genomic era. The American College of Medical Genetics and Genomics has defined competencies for the physician medical geneticist. This particular competency focuses on translational research and clinical trials, which have become a kind of mainstream aspect of genetics practice, and this one on providing counseling to individuals based on genome or exome sequencing. So there's been a lot going on there. ACMG has also been working to try to increase the pipeline, encouraging students to, medical students this is, to be aware of career opportunities and to be connected with the genetics programs at their institution. Now for the past 3 years, the Summer Scholars Program has taken medical students, one student, sometimes two, in 10 to 20 institutions around the country that apply for a slot, and these students spend the summer with a stipend provided through ACMG Foundation to actually work in a genetics unit, observing clinics, participating in lab activities, sometimes picking up a project. It's been going only a few years, so it's probably too soon to judge how successful it will be, but the hope is that it will provide a kind of sensitization to the opportunity that will bring more people. Now, we don't need every third medical student to go into genetics, but there is the possibility of doing a genetics residency, and certainly the opportunities to increase the numbers are really quite significant and important. We also, I think, when it comes to educating the generalist physician or specialist in other areas, need to realize not everybody by any means is going to do a genetics residency, which is a 2-year residency, by the way, that is recognized by the American Board of Medical Specialties. But not everybody is going to go that route or should, and that we need to use every opportunity at our disposal to educate the workforce through new educational paradigms. I show here examples of the massive open online courses, Khan Academy model for delivering micro lectures on different topics. We created an iBook here at UAB to support a course we give on genetics and genomics and clinical research twice a year to clinical investigators, and other novel paradigms such as this one can be used as well. So there'll be lots of opportunities to try to develop new approaches. Well, so what ultimately is needed? And I will identify a few things going forward. The first is really more of a scientific challenge, but we are a long way from having a fully annotated genome, which means that it's going to be a long time before you can take genome sequence at face value and just say, well, you've got this variant and here's what it means. That is true for certain variants. It is not true for many. And knowing the difference between the two is what the kind of professional training really needs to accomplish. Second, as I've alluded to many times, we need point-of-care decision support tools to be deployed to support the clinician in things that you just can't reasonably expect them to remember. how to adjust drug dosage based on a particular pharmacogenetic test is a kind of, in my mind, obvious example. As risk assessment comes of age, I think that will similarly be an example of something that will benefit greatly from point-of-care decision support tools. Thirdly, none of this is going to happen without collaborative partnerships. As an example, the generalist physician should be in a position to recognize the new technologies that their patients could benefit from. And just like in the case of inborn errors of metabolism, will very likely want to identify a consultant expert who can help. I hope a medical geneticist will be on their list of people whom they might call upon in those situations. But nonetheless, they have an important role to play. I certainly would not posit that specialists, say cardiologists or neurologists or oncologists, are inevitably always going to refer to a medical geneticist every time they want genome sequence. It's pretty clear that won't be the case. I strongly favor the notion of creating focused fellowships that a cardiologist could do, say a one-year fellowship in cardiovascular genetics that does not require them to master all of the details that a medical geneticist would master. If you're an adult cardiologist, you probably don't need to know a whole lot about treating newborns with congenital anomalies. So creating partnership-focused fellowships is something that I strongly favor, and where there have been active discussions to create those kind of training paths. And I do think we are going to need new counseling paradigms. When you've got a genome's worth of information to discuss with an individual, you can't sit in the room going gene by gene. So I think we do need to have new ways of imparting information, probably some of which will be web-based, various apps that may be able to customize the message to the particular genetic findings of a given individual. I think there's huge opportunities in sort of the entrepreneurial world to be building both new educational and new counseling approaches. So I think, in summary, I'll make the point that although there are many cautions I think I have alluded to in this talk so far, I'll tell you that I tend to be optimistic about how all of this will play out. I strongly believe that genomics will be a major engine of progress in medicine in the coming generation. Not the only one, but one of the major ones. And for all of the challenges, I guess my fundamental belief is that the medical community has risen to challenges like this before. I would cite imaging as an example. When I trained, MRI was just beginning to be introduced, and now it's used on a routine basis, and I think in general well used. I'd be hard pressed to tell you any great detail about the basic physics of MRI, but it hasn't stopped me and my colleagues from using it on a routine basis, and I think to the better health of our patients. I think the same will happen in genomics. The main way to look at this from my perspective is this means new opportunities for those who are inclined towards sort of creating cutting-edge paradigms. And in my mind, that's what makes this time really such an exciting one in which to be practicing. Finally, I need to direct you to this website, or this link. Apparently, the actual link is not functioning, but I'll take questions in just a moment and leave this slide up. But those of you who are interested in continuing education credits should know that you can go to this link and arrange to get your CMEs. So I will conclude at this point. I very much appreciate the opportunity to participate. I hope this was helpful, and we'll then take questions, and I noticed that there are some. So I guess one question was, how do we get the PDF that I publish? I think what you're referring to probably, the PDF of this presentation will be available on this site, but that may not be what you're referring to. I wonder if you were referring instead to the iBook that I alluded to a few slides back. So that is not in the iBook store. It actually was for a few minutes, but we realized it was probably didn't belong there because these were slides prepared for a particular course that is really very narrowly targeted. And we're in the process of kind of upgrading it so that it's available on a more general basis. Anybody specifically interested can send me an email, which is bkorf@uab.edu, and we can talk about how to make that available if that's what you're interested in. I don't see any other questions on the display. I guess I can pause for a minute and see if any come through the system. Okay, so the question is, there is seeming disconnect between physicians and advanced knowledge, especially in basic sciences. How can this be bridged? So my answer to that, I guess it comes back to that HHMI AAMC document. And I thought the point of that, first of all, was to rethink the way basic science is taught and to focus on the things that really matter in terms of clinical action. Because at least in my mind, the goal is that you want physicians to be inquisitive and to be interested in and alert to what the basic science underpinnings of their practice are, but you don't necessarily expect that they are going to be sort of experts at the basic science of every fine detail of everything that they do. And going back to the example of imaging, I told you before, I don't really understand the physics of MRI, and I'd be very surprised if many of my colleagues did. But the truth is, I actually think that the kind of general ability to have an idea of what's being done with an MRI and what the different sequences are good for identifying has benefited from having some basic science knowledge of NMR and realizing that this is not a black box that magically produces pictures and that there are ways of getting artifacts. So having some basic science knowledge there helps, even though you don't consciously use it every time. So I think we need to rethink the way medical school curricula are organized, the way the pre-health professional curricula are organized. And I think we need to embed this in the point of care and into the CME opportunities. But not, I think the biggest mistake we make is by going into such fine detail about the nuts and bolts of the basic science that it loses people and they don't really see the value. It's not an easy area, but I do think that it can be done a lot better. So there's a question, I guess it refers back about the book that we published for clinicians. And I'm not actually sure what book that was referring to. The only book I spoke about specifically picturing the slides is, I don't know if I can go back to it. It was, I believe, this one here. If that's the book that's being referred to, that's the iBook I was talking about before, that I'd be happy to share as we sort of upgrade it. And I mean, there are many books out there, and I won't go into details about individual books, but there are many that are available that can be used to get up to speed on this. And there's a point, I believe it is equally important to educate patients on genomic interpretations so that they can have productive conversation with their physicians and a successful overall outcome of clinical care. So I absolutely agree with that. And, actually, I go back to the slide. That was the point of this slide. The idea was that, the general undergraduate, and I realize obviously this is relevant to people other than those that go to college, but I would make a strong argument for incorporating some of the very elemental principles into secondary school education and into, certainly into post-secondary education. I think the scientific community needs to be prepared to articulate the opportunities and the challenges in a clear way to the consumer public, the general public. There are various efforts to do this on a formal basis, web-based efforts, for example. I know that some groups have put together that are available. I think it's another area of huge need and opportunity and has to be done carefully and well. And what I mean by that is, the same temptation to delve into the kind of weeds of all the details is a real mistake because it creates the impression that this is too complicated to possibly understand. And I guess one of the central messages of my talk is this is more complicated than it seems, and therefore needs to be done carefully and thoughtfully by people who know what they're doing. However, as any complex area, there ought to be a way to communicate the sort of the core of it so that people understand it and are not afraid of it. And part of course, having them not be afraid of it is to instill confidence that the people that they're able to talk to about it actually know what they're doing. But I think a partnership between informed patients and consumers and informed professionals is really the goal that we should be seeking. All right, I don't see any other questions. I'll pause again in a minute in case any come along. Will we be able to review the lecture? It's my understanding that these are archived and available for view after this session is over. So I'm pretty certain that the answer is yes, though I guess you'd have to contact one of the people involved in setting this up to know exactly how it's done, but yes is the answer. Okay, any other questions? All right, well, I think we are pretty close to the end of the time. I guess I will conclude at this point. Really appreciate your attention and interest, and hope that this was helpful to all of you. So thanks very much.